My task was to discuss the multiple blood pressure goals and how do we decide for treatment of hypertension, since there's more new clinical trials coming out. In the recent years, many organizations have issued very different divergent recommendations in how to treat hypertension in different people, like people with diabetes and high blood pressure, or older patients, and that leads to a lot of confusion in when to start treatment and how intensive is the treatment should be. And so I was going over the literature, and again, I think that there's going to be a revision of the guidelines in the next 2 years, again, because of a few new clinical trials that come out. I think the first thing is that they need to know what are the comorbidity, what are the any concomitant vascular problems, and if they don't have heart disease yet, do they have risk factor for heart disease? And I think the largest study that's NIH-sponsored trial in this country, the SPRINT trial, tell us that people with coronary artery disease or people with high risk of having coronary artery disease actually do benefit from intensive blood pressure reduction. So they actually trigger the treatment even at the lower threshold of 130, the top number 130 millimeter mercury, and to get it down to systolic less than 120. Obviously, that's only a subgroup, but the interesting part about that is that that has not been something that we thought about much, to incorporate the cardiovascular risk into the how to treat high blood pressure. Previous studies that look at patients with diabetes and high blood pressure did not find that intensive lowering of blood pressure improved the long-term outcome, but it turned out that perhaps those study was a little bit too small to address that. They estimate the risk of people in the control group to be a lot higher, but then with the modern treatment and risk factor control, the control group have much lower risk, so they weren't able to discern. But the new analysis from the ACCORD trial in diabetes show that perhaps they do derive benefit, after all, in a more subtle way from intensive lowering of blood pressure. This ACC, there's a new clinical trial that just came out called HOPE 3, which show they did a little bit of different study design. They just they don't have an entry criteria. So anyone who have low to intermediate risk was enrolled. But they don't have interestingly, they don't have an entry criteria for blood pressure. As long as they don't have, the doctor feel like they don't have low blood pressure, that symptom, they can enroll, and they just give a fixed dose of medication, candesartan, hydrochlorothiazide, low dose, and they did not find a benefit over 5 years. I think that take-home message from that trial and it reconciled with the SPRINT and ACCORD. Perhaps in people with lower risk, you don't have to treat, particularly if you don't have high blood pressure to begin with. Giving medication probably won't be a good thing. But the HOPE 3 actually tell us that in those populations, giving statin is helpful with lowering cardiovascular events. I think that we have to look at the population who we treated. I think people who older patients and African Americans tend to be salt sensitive and have low renin, and I think the guidelines would recommend to start either with the diuretic or calcium channel blocker first, because of the track record in lowering stroke, and which I agree. For younger people, not necessarily a low renin type of hypertension, then start with ACE inhibitor or ARB. I think that will be that's my approach as well, and that's what's recommended in the recent JNC 8. There's several factors. Obviously we have plenty of salt everywhere, so that a lot of sodium contributes to uncontrolled blood pressure, obviously weight gain, and the other challenges would be if you want to get the blood pressure to that low, intensive lowering of blood pressure, you need multiple medication to get there, and the challenge to how to keep the people taking that long term. I think I would recommend, I actually take a lot of ask the patient all the time to measure the blood pressure at home, because when they come to the office, they tend to have a white coat reaction, and particularly in older patients, and that might not necessarily affect what's happening at home. Although we did find in the population-based study in Dallas that white coat hypertension is not necessarily a benign phenomenon, but if we wanted to treat the patient to goal and we want to avoid over-treatment, I think we do need to know exactly what levels they are, and so that we won't cause kidney problems and low blood pressure, fainting. I recommend them to check blood pressure regularly. I typically do it 3 times because the first reading tend to be the highest and they settle down the second and third. Well, there's still a lot of futures that in terms of not to how to roll out these findings from the clinical trial and clinical practice, because most of the time the blood pressure measure in the clinical trial were done in such a careful way that the patient rests for 5 minutes. They did it 3 times on average, all 3. And in basic clinical practice, usually the doctor doesn't have time to do all that. And what would be the most practical aspect to roll this out would to get a good reading and to apply what we learned from clinical practice to a broad range of patients and to deliver the care effectively and to see the same benefit. I think that's the challenge we need to know.